Okay, so with that, let me introduce Dr. Fiske. Dr. Fiske received her Bachelor's of Arts degree in English from Stanford University, her Master of Arts degree in Social Psychology from San Francisco State University, and her doctoral degree in Clinical Psychology with a focus on aging from the University of Southern California. She completed an internship at the Veterans Affairs Palo Alto Healthcare System. She completed postdoctoral work and a visiting faculty appointment at the University of Southern California and joined the faculty in the Department of Psychology at WVU in 2005. She was promoted to associate professor in 2011 and currently serves as the department as Director of Clinical Training and Coordinator of the Clinical Psychology Program area. So I'm so happy we stole you from California system and that you've been able to stay with us. And with that, let me turn it over to you for your talk today.
Great, thank you, Dr. Cottrell, I appreciate that. And I'm really excited to be here at the Center for Excellence in Disabilities, at least at virtually, to talk about this because when Dr. Cottrell spoke to me about the possibility of doing this talk, it helped me really see what an important role disability has played in my research program. So this has been fun for me to go back and really look at this in a way. So thank you for having me today. What we're going to be doing today is I'll basically give you the conceptual framework that my main part of my research program has been based on. And it's really looking at functional disability, functional impairment, and either depressive symptoms or suicidality in older adults. And I'll give you the conceptual framework that comes out of a lifespan developmental theory. And then we'll talk about some of the things that might explain why functional impairments are related to especially suicidal outcomes in older adults. And some of these include attitudes about autonomy, coping strategies, cognitive flexibility, and even actually engaging in pleasant events. There are things that my lab has looked at in relation to depression and suicidality. So first, I just want to mention, though, a little bit about depression. Most people are pretty aware of how common depression is. And in lifetime depression, about 19% of people in the United States will get depressed at some time during their life. And the 12-month prevalence is, of course, a little bit lower. But the interesting thing is, as you can see from those age groups, that old age is actually the time when people are least likely to be depressed. I ask you to think for yourself, is that what you would have expected if you didn't already know these statistics? I think most people think of old age as pretty depressing, but here's the takeaway from today's talk. That's not actually the case. It is true, however, that older adults are more likely to have, or at least as likely to have, lower level depressive symptoms that don't meet criteria for a depressive disorder. But could be clinically significant. And then in addition to that, any depression is it puts a person at risk for some pretty negative outcomes. One of those negative outcomes is suicidal behavior. About 1 million people every year die around the globe of suicide. And in the United States, in the most recent year for which we have complete data, which was 2018, almost 50,000 people died by suicide. Sadly, those rates have been increasing recently. It now is ranking as the 10th leading cause of death among anyone in the United States. And as you can see, the suicide rate per 100,000 for the general population, 14.8, it's actually, well, the interesting point is it's actually much higher than the rate for homicide, even though you hear about homicide a whole lot more. But the rate actually goes up in late life. So as you can see, it's 14.8 in the general population, 17.4 in people 65 and older, even higher in people 85 and older. And most of those suicidal deaths in late life are older men. For women, the suicide rate actually drops off in old age, but for men, it climbs. So one of the questions that's been driving me in my career is, what might be the reasons that older people might be more suicidal, given the fact that we know as a group that they're less likely to be depressed, and depression is one of the main risk factors for suicide. Here are some of the other risk factors for suicide. And if you look at some of these, you'll see there are certain stressful life events. For example, in the study I did, the most prominent stressful life event for older adults was loss of financial status. So people's income dropping. And surprisingly, that was in Sweden, where it was a socialist country and probably there's more income protection than a lot of other places. But still, that was an issue for a lot of older adults. But the one I want to talk about today is physical illness and disability, because that really stood out to me as one of the challenges that occurs more frequently in late life and could potentially explain why more older adults might be turning to suicide. So to explain this, I turn to a theory of lifespan development called the motivational theory of lifespan development by Heckhausen, Rosch, and Schultz. And this theory placed control front and center. They said that successful aging is a matter of how you manage control, how much control you want and how much control you have. And they break down control in two different ways. And this is based on Rothman et al. Primary control is if you are actually operating on the environment. You're doing something to reach your goals through your own steam, basically. That's primary control. Secondary control, in this theory, is conceptualized as a way of altering yourself so that you can enhance your motivational resources to pursue primary control. Okay, so primary control is really viewed as the most important thing in this theory. And you have to ask yourself, does that make sense to you? I mean, certainly I think most people would agree that given a choice, you'd like to get things done yourself. We're kind of a do-it-yourself species. So this schematic gives you an idea of what premises this theory is based on. One is that we all like to have control. And if you look at the primary control striving line at the top that goes steadily across the lifespan, and the trajectory for that is proposed to be just steady, because they would argue that everyone likes to have control, no matter how old you are or how young you are. And so striving for control is a constant in this theory. What does change, however, is our capacity for control. So those who work with kids know that most kids probably don't have a lot of control and probably feel like they don't have a lot of control, but that does increase as they gain competencies and gain age. However, in the latter part of life, things happen that lead us to have less capacity for reaching our own goals, just using our own independent efforts. So as you can see in the schematic, the primary control capacity drops off in the latter half of life. And that's the challenge. How do you meet your goals when your ability to do that under your own effort is declining? And one thing they're suggesting in this schematic is you can use secondary control striving. In other words, you can enhance your motivation, and you can use some other secondary strategies I'll tell you about in a minute. The other elements that Heckhausen, Rosch, and Schultz have included in their lifespan theory include selection and compensation. And for those of you who know much about lifespan development, you'll recognize that as coming from the Baltus and Baltus selective optimization and compensation model. And the notion is these are things we have to do. These are challenges that we need to meet in order to age successfully. Selection involves just the fact that we can't do everything we want to do. So we do have to pick and choose, right? So selection is just figuring out where to invest your resources. And that's something we do throughout the lifespan. Compensation is something that you have to do because into everybody's life, a little bit of rain's going to fall. Sometimes you don't succeed. And so how do you deal with losses? And how do you deal with failures? The answer is that they would refer to that as compensation, whatever you do to adjust for that. So these control strategies that Heckhausen, Rosch, and Schultz talk about include, can also be classified according to these regulatory mechanisms of selection and compensation. So they would say selection is investing in a goal, and compensation includes responding to loss and failure, either by amping up your action plans, in other words, changing what you do, or protecting your motivational resources. And maybe none of you recognize this, but some people do, for example, say, well, I didn't really care about that goal after all. Or I know I didn't make that goal, but it really wasn't my fault. Okay, so whatever we have to do to protect ourselves would go into that secondary, the compensation category. So if you cross both the primary, secondary rubric with the selective compensatory rubric, you get this list of control strategies. And in this theory, they would argue that all of these are adaptive. What makes a difference in what is adaptive in a given situation is what the opportunities are. So these first three goals, these first three control strategies involve engaging with your goals. So again, selective primary control is you're out there trying to change the environment, you're doing something to meet your goal. If you don't have any groceries for dinner and your goal is to cook for dinner, then you're going to get in the car and you're going to go out there and drive and get your groceries and come back. That's selective primary control. It's that simple. Selective secondary control is arranging your motivation, preserving your motivation so that you can basically do your primary control striving. So it is organizing your time in such a way that you might have time to go out to do the groceries, avoiding distractions. You don't sit and watch TV, you actually go out to the store and get your groceries. Compensatory primary control, and this is the one that I'm going to be talking about most in my research, is how do you adapt if you can't meet your own goals through your own efforts? And you might do one of two main things. One is seeking out help, and two is you might find a different way to reach your goals. So possibility is ask your neighbor to drive you to the store to get the groceries. And another possibility would be you might learn how to use the mountain line. Go out and go to the website and look up their route map and figure out where you can catch a bus and get your groceries that way. Then the latter category here at the bottom, goal disengagement, includes the compensatory secondary control. And what that is basically giving up on a goal and picking a new goal and making yourself basically arranging so that your motivation will continue to be high to meet your new goal. Okay. So I like this theory so much that I basically took this and put it into my own model just as a way of organizing my thinking about what I wanted to learn about late life suicide. So as you can see, my thought about this is as we get older, physical and cognitive and maybe even financial limitations lead us to no longer be able to meet our goals in the same way we used to. And if that's the case, then it's adaptive to use compensatory strategies that I mentioned, either help seeking or modifying the way you get to your goals or modifying the goals. And some people are going to do that. And those are going to be the people probably who are going to land in the category of successful aging. These are going to be people who are generally going to be having higher well-being. On the other hand, there's some people who are not going to be engaging in these compensatory strategies. And I would argue that these are going to be the people who are not going to actually meet their goals, because at a certain point, especially among people with functional impairment, that might be continuing. If you get to a point where you can no longer drive, or you can no longer walk, or there are lots of things you can no longer do, perhaps due to cognitive reasons, you will be unable to meet the same goals in the same way. And if you don't compensate, I think that's a recipe for hopelessness, which is, of course, another risk factor for suicidal ideation. I have a couple of boxes down here at the bottom, and those are things that I speculated might lead into whether or not a person would choose to do the compensatory strategies. So those people whose attitude toward independence is they're so fiercely independent that they really place a high value on their own autonomy, I would think those people would be less likely to use compensatory strategies and therefore more likely to be hopeless, depressed, and suicidal. And eventually, that is, if their functional impairments get bad enough, And then people who have an inflexible cognitive style might just not change because you need to be a little bit flexible to change. So they might not take on compensatory strategies, not because they don't want to, they don't like those strategies, but just because they've always done it the other way and it's always worked. So I set out to test a few of these things. And the first thing I wanted to test, I was just fascinated with that attitudes toward autonomy. I think we've all probably known fiercely independent people, and I was really interested in seeing what we could learn about that. So that's one of the first things I tackled. But first we looked at whether physical illness was even associated with depressive symptoms in a longitudinal data set. And I did, through my mentor, Dr. Margie Gatz, have a lot of access to Swedish twin data. I worked on that with her when I was in graduate school. So I had a longitudinal data set here of older adults, a large longitudinal population-based data set. So we took depressive symptoms using the CESD and looked at that in all of the twins in the data set, age 29 to 93, but divided them up at age 60. We found that depressive symptoms actually increased in the group 60 and older, but not in the younger group. And what we found cross-sectionally is there was an association between illness and depressive symptoms, but it wasn't as clear longitudinally that there was an increase. There was at baseline in our longitudinal models, but not a change over time that could be attributed to illnesses. We then set out to do a review of what the literature said about illnesses and suicide risk, and found that some illnesses were related to suicide, death by suicide, and others were not. It was, you can kind of see the list here. And then we looked at what some of the commonalities might be. And one of the things we noticed is some of the studies talked about the death by suicide was more prevalent around the time of diagnosis. Others said it was more prevalent later in the stage of the disease. Cancer, for example, actually has elevated rates of suicide both around diagnosis and also late stage in the disease. So we thought that might have different implications as well for functional decline and functional impairment. And then what are the mediators for this? It was not clear enough from the literature at that time. Not a lot of people were really looking at that, but we did think functional impairment was important. So that led us to do another study where we actually looked specifically at functional impairment. So in this study, it's the shared data set, which is publicly available, or at least available to researchers. And it was from a number of different countries in Europe. It's a large data set. And we looked at all the different medical conditions that they measured, and we looked at their functional impairment. I think it was activities of daily living that they measured. So you can see there the list of all of the diseases that we found were related to passive suicidal ideation in this study. And by the way, passive suicidal ideation is basically a wish to die. So it's a little bit less explicit than saying that you had suicidal thoughts, but it's kind of getting at that same construct. And we also looked at different organ systems as well to see which ones were related to passive suicidal ideation. And we found a number of them, as you can see listed. And we also found that those illnesses were partly mediated by functional impairment and partly mediated by depression. Okay, so this gave us kind of a clue that we were on the right track looking at functional impairment, not just illness. And then my student, Julie Lutz, wonderful student who just recently graduated, and she did a critical review looking at functional impairment and suicidal ideation specifically, looking at all the studies that were out there at the time, 45 studies looking at that. And what she found was that there was strong support for the conclusion that functional impairment was related to suicidal ideation. There was also some suggestion that depression might mediate that relationship, but not enough of the studies had actually even tested that to be able to say that that was the case. Oops, sorry. So The next thing we looked at was, as I said, I was aching to look at um, people who had fiercely independent attitudes when it came to autonomy to see whether that might explain why, that might explain some of why people were suicidal in late life, or depression in late life as well. So what we did is we found a measure of value placed on autonomy. And basically it was the same measure we used in the, oh, I'm sorry, maybe I'm confused. So this is a measure that we had used to mail out to people in West Virginia, older adults in West Virginia, as well as the surrounding states. And, sorry. Okay, I just want to make sure I was in the right place. And the measure, basically, the autonomy measure had these subscales on it. The one I was especially interested in is need for control. And that representative question for that is, I resent it when people try to direct my behaviors or activities. The measure also had some other subscales on it, perfectionism and defensive separation. But I was pretty much hypothesizing that need for control would be important for older adults, just because we think that we know that older adults are more likely to have functional impairment. So the idea is that independence may be more of an issue for them. And so we looked at that. And as you can see, each of these three areas, I don't know if there we go. Each of the three areas, subscales, were at least moderately correlated with one another, but only the need for control subscale in the older adults was related to the measure of suicidal behaviors, the suicidal behavior questionnaire, in this older adult group. We then went to college students and took the same survey basically and sent it out to a group of college students and found exactly the opposite. So for the younger people, need for control was not related to suicidal behavior, but the other two subscales were. So again, that really kind of confirmed for us that control was an important factor when it comes to older adults and suicidal behavior. So we did another study where we actually went out and recruited older adults in the community and then gave them some questionnaires. And we wanted to look at, again, their attitudes about autonomy and see how that might have been related to suicidal ideation. What we found, as you can see from this hierarchical linear regression, is that depressive symptoms measured by the CED were related to suicidal ideation, as you would expect, and so was autonomy. But that was also qualified by the fact that there were a couple of interaction terms that were significant. And so we interpreted this latter interaction term between depressive symptoms, value placed on autonomy, and gender. And what we found was we interpreted that interaction term, and what you can see here is that higher levels of depressive symptoms are related to higher levels of suicidal ideation, but that relationship is not at all affected by whether you have high versus low levels of autonomy, okay? So in women, I'm saying it was not related at all. We did look at it in men separately, and lo and behold, it makes a huge difference. So for men who place a very high value on autonomy and independence, that very much amplifies the relation between depressive symptoms and suicidal ideation. That's how we interpreted that. So this was an interesting area, and we kind of took away from that how much you value your own independence is going to be an important thing when it comes to suicidal ideation, if only because it works through depressive symptoms. So the next thing I decided to do is look a little more directly at some of these control strategies, because if somebody places a high value on their own independence, then this is the kind of person, as I keep saying, who's fiercely independent. this is probably not somebody who's going to want to ask for help, right? And that was one of those two strategies that I mentioned in the compensatory control, primary control strategy category. So one way in which you can compensate is you can ask for help. Another way is you can just modify your method of reaching your goal. But we think that people with high levels of autonomy might not want to ask for help. And so I decided to do a little bit of research specifically about compensatory primary control. So what we did was we went into a primary care setting and arranged to be able to interview some of the older adults who came in as patients in their waiting room. And we did that. So we ended up with, we also then pulled out the group that had impairments due to their health. And we did that using those two questions that I have listed. Either they had endorsed some kind of limitation in their activities of daily living, or they answered yes to the question, does your health keep you from doing things you'd like to do? So we had 50 people in this sample, age 65 to 94. And you can kind of see what some of the problems, health problems, those were the main health problems that they endorsed. These are the demographics of the sample. That's probably not terribly surprising for this age group and in this town. Actually a very high level of education, as you could see, which is not unlikely for Morgantown. Their depressive symptoms in this sample were, below the cutoff on average, but they were not negligible. And the geriatric suicide ideation scale, they did also have a mean of 12, but the cutoff is 19. So they're not on average, not in the clinical range, but that does show there was enough variability that we did get a little bit of depression and suicidal ideation in the sample. So if you looked at both for depressive symptoms and suicidal ideation, we wanted to know how these control strategies predicted those affective outcomes. And what you can see is for the for compensatory, I did this two ways. For compensatory primary control, we looked at that as that scale directly, but we also looked at the two subscales within that, one for help seeking and one for modifying the goal. And what you could see is help seeking is where the action is, right? So those people who endorsed that they did ask others for advice or help were less likely to report depressive symptoms. They were also slightly less likely to report suicidal ideation. However, that was not significant in the sample. When we just looked at compensatory primary control, that CPC scale altogether, instead of breaking it into subscales, it was significant for suicidal ideation. If you look at those secondary control strategies, that compensatory secondary control, which is giving up on your goal, finding a new goal, maybe helping yourself feel better about that, you could see that's also significant, but that's significant in the wrong direction. So those people who did that were more likely to be depressed. And those who engaged in selective secondary control, trying to amp up your motivation, were more likely to be suicidal. And the only explanation I can say for that is these are cross-sectional data. So it may be the case that those who were more depressed or those who were more suicidal were trying harder to work on themselves and get their motivation in place to be able to do better. So we wanted to then, given the fact that help seeking did seem to be related to depression and also suicidal ideation, when you take that full scale together, we wanted to look at that in a little bit more detail. So, and we also had found that selective primary control, which is persisting and trying to meet the goal with your own efforts, was also significant, at least I think, for depression. So what we did is we looked at the interaction between the two. And what we found, I'm pleased to say, is exactly what we would think might happen. And that is those people who were doing the best are people who were either high in selective primary control, which is persistence, or high in compensatory primary control, help seeking specifically. Okay, and so these are, if you had, and this makes sense. Why does this make sense? Because if you are able to reach your goals by persisting, you wouldn't need to be compensating. And if you were compensating, you wouldn't need to be persisting. You really just need to have one or the other. And that just makes a lot of sense to me. So that gave us cross-sectional evidence that there was some relationship between control strategies and suicidal ideation and depressive symptoms. But what we then wanted to do, what I needed to do next, is find out, is there a prospective relationship between these things? So I did a little pilot study. It didn't feel little while I was doing it because I drove all around West Virginia to meet with people in their own homes, at least for the baseline interviews, and then did telephone interviews after that. And it was a longitudinal study for a year. As you can see, we collected data both at baseline, 6 weeks to kind of capture change happening immediately after the baseline, 3 months, 6 months, 9 months, and a year. And I basically went to the cardiology department and got referrals from them of people who had had a recent, meaning within the last 6 months, heart attack or congestive heart failure. And the idea for getting a sample of that kind was my thought that this would be a way of getting people with who are going to be vulnerable for functional impairments if they didn't have them already. So I was expecting some decline over time in their functioning and potentially decline in their affective outcomes as well. And the question was going to be, do compensatory primary control strategies predict that decline? Well, what I found was I did run some cross-sectional results, and I found compensatory primary control was significantly associated with virtually everything I was interested in: depressive symptoms, hopelessness, and suicidal ideation. And that was significant, even in a sample of 10 people. So as a pilot study, I was kind of impressed by that. Selective primary control was not as consistently related, but the trends were all in the right direction as well for selective primary control in these cross-sectional results. When we looked at this longitudinally, and what you can see, I think you should focus on where it says effect size over 1 year. You can see there's at least a moderate effect size, or small to moderate, for depressive symptoms, the CESDR, and for suicidal ideation, the GSIS. So this gave us, although these were not significant, of course, for CESDR, it's pretty close to significant, 0.08. But what this gave us is a signal showing that compensatory primary control at baseline did appear to be predicting changes in the expected directions in CESDR, in depressive symptoms and in suicidal ideation. And so this kind of led me to believe the most important thing next is to do a larger study with a larger sample to be able to see if these findings are borne out. One of the other things we looked at in this study was cognitive flexibility. So while I was driving around to people's homes in West Virginia, which was, by the way, really a fun thing to do, and one of the things that kept me here from California, because I have to say I've really, really enjoyed meeting and being around people in West Virginia, and the natural beauty was great as well, so I really enjoyed the driving. But one of the things I did is, the reason I had to do this in person, is I wanted to do the Wisconsin card sorting test. And the reason I wanted to look at flexibility is because there is some evidence showing that personality-wise, people who have openness to experience to a greater degree are less likely to die by suicide in older age. And I thought, aha, that kind of lines up with this idea, doesn't it? Maybe if they're open, they're flexible to taking on compensatory strategies and changing what they do. So I wanted to look at that, and I did, and did not find any results, unfortunately, with that personality measure. But I did also add the Wisconsin card sort test which, as you may know, is a test that basically has a game you're playing with the participant, who then, and then the rules of the game change in the middle of this sort of card game. And the test is trying to see whether they will catch up, whether they realize there's been a change, and whether they make a change in response to the changing rules. And for people who do not change during this test, basically those are referred to as perseverative errors. They're perseverating, continuing what they were doing, even though it's not working. And so my thought was, maybe this is a measure of cognitive flexibility that can help us see whether somebody might be, it might lead to whether or not somebody's suicidal in old age, as they have functional limitations to deal with. And what we did find is that if you look at these different control strategies, selective primary control, compensatory primary control, and then the secondary controls as well, the only one with significant correlation is the compensatory primary control. So that suggests that it takes a little bit of cognitive flexibility in order to shift over to the compensatory strategies. We did find that those higher levels of perseverative errors were related to change in hopelessness with a moderate effect size. They didn't predict suicidal ideation or depressive symptoms, but again, this is only 10 people, so that's probably the reason for that. Then another one of my students in my lab came up with an idea, Patty Bamonte, who's now at the VA in Boston, and she came up with this great idea of looking at taking people selected for functional impairment and figuring out whether engaging in pleasant events could explain why these people either did or did not have some affective outcomes, again, depressive symptoms, as well as positive affect and meaning in life, which is highly correlated with suicidal behavior. So she recruited these people in the community, again, older sample, and mediation analyses found that physical disability was associated with greater symptoms, lower positive affect, and lower meaning in life. And this was indirectly through, in other words, mediated by the extent to which they engaged in pleasant activities. And this is good news for those of you who may know a little bit about something called behavioral activation. It's a therapy that we use to treat depression. And one would assume that that would be a good therapy to use. And it's certainly empirically supported in all other groups as well. But the question is this a treatment that would actually work with people who have disability, functional impairments? And the answer is this research really suggests that it is. It's also true that for somebody with impairments, it might be important, however, to help the individual figure out how they're going to engage in pleasant events, especially if it's a new impairment. They might not be able to do what they used to be able to do to engage in pleasant events. So going back to this original model, I would say I think we do have at least a little bit of evidence that engaging in compensatory strategies is associated with hopelessness, suicidal ideation, and depression in late life. And we do know that cross-sectionally have a little signal of that in terms of prospective research, but need a little bit more prospective research in that area. I'm trying to get a study funded to do that. We do have some evidence that high value placed on autonomy is related also to hopelessness and suicidal ideation, but we'd need to know, an interesting question might be, does that actually relate to people not engaging in compensatory control strategies? Don't quite know that yet. And we know a little bit about inflexible cognitive style being related to compensatory control strategies and also suicidal ideation. So future directions, I would like to test, as you can see, what I've done in my research so far is to try and select for samples that have or should have some form of functional impairment, and then see whether these relationships hold in that sample. I'd like to take a larger sample that has people who do and people who do not have functional impairments, and see whether we can test directly for functional level of functional impairment, and see if that then predicts these outcomes and whether it's moderated by coping strategies. The other thing we need to do is, as I mentioned earlier, we need to take the cross-sectional findings and test them in a larger longitudinal or prospective data set. Then I think we need to maybe develop some interventions to help people learn to ask for help, for example, and feel better about it, or to help people come up with flexible ways of meeting their goals, and test those out, and whether those alter our affective. If we do intervention studies with those methods, see if that alters the affective outcomes. And also, I'd love to just know whether autonomy is related to people doing compensatory control strategies or not. So I think we've gone over these conclusions already. I think there is some evidence that functional impairment is a huge challenge for older adults, and is definitely related to depressive symptoms, hopelessness, and suicidal ideation. And I think we've got to start on finding some ways to look at those and maybe explain what those relations might be. So again, I very much appreciate being asked to be here to talk. I also would like to acknowledge some grant funding that I got that helped with some of that research. One of my colleagues out in California that I'm still in touch with, who's really helps me a lot with my statistical work as well, and all the students past and current in the mental health and aging lab who work with me. I really appreciate them as well. So I am open for any questions people might have. Is it okay if I go ahead and stop my sharing at the moment?
Absolutely, that sounds great. And I see we already have one question in the chat. And then as people have questions, please remember to unmute. So are you able to see the chat? The first question is, so how is COVID-19 and increased isolation impacting suicidal ideation in older adults and suggested strategies?
Well, suicidal ideation is actually increasing in COVID-19. You might have heard that already. And that's true, I believe, in older adults as well as in other age groups. And one of the things that I've been really interested in recently is how social factors might have something to do with the control strategies people use, because help seeking is not going to do you any good if you have nobody to ask for help, right? So I'm just seeing this among people that I know, that people are sometimes having some difficulty finding anybody to help them out. So I think that's a big issue. But that was one of the directions actually I wanted to head in a future study, to figure out whether those compensatory control strategies are actually facilitated literally just by the presence of another person. Great question.
The next question, are there differences found in compensatory strategies of individuals who have chronic lifelong disabilities and those who acquired a disability later in life? So depending on when.
Yeah, that's a great question. I'm going to write that down. I would love to study that, and have not actually, I have no data pertaining to that right now. I've been especially really interested in people who develop functional impairment late in life. And the reason for that is that there is a little bit of research on Heckhausen, Rosh, and Schultz's theory as it pertains to Hans Werner Wahl did some research on people with age-related macular degeneration, and found that as that got worse and people lost their eyesight in both eyes, you could actually see people shifting from the persisting to meet their goals, that selective strategy, to a compensatory strategy. And I thought that would be kind of an interesting way of watching that happen kind of in real time. But it would be great to just compare those two groups. I think that'd be interesting. Thanks.
And then Grace is listed, what can society do to improve the assistance availability / accessibility so that if and when people ask for help, it will be given to them in an effective way? Also, is there evidence of comorbid traumatic events earlier in life that may contribute to these issues?
Again, really good questions. There are a number of ways in which I think communities really do a nice job of helping older adults who might not want to ask for help. One of the experiences I had when I first came to West Virginia that really stuck with me, I went over and met with some folks over at Scott's Run in the senior center there. And I was asking them about, I was fascinated with this whole idea of help seeking and how people view autonomy. And I was asking them some questions about that. And I said, would you, because I was meeting with these older people, I said, would you ask for help if you had a problem you couldn't solve on your own? And they said, oh, no. And I thought, that fits into my stereotype of West Virginians as being fiercely independent, right? And I asked, is that what you mean? You would want to do it yourself? And they said, oh, no, it's that you would offend the person you asked because they should have known to offer. And I thought, oh my goodness, this is a place where people who've lived here a long time maybe have such a norm of helping each other that that it's taken for granted that you're going to do the help, giving help. You shouldn't even have to ask for it. And I thought that was stunning. That really touched me. And so I have seen, even since I've gotten here, and some of my graduate students as well mentioned that there's a whole lot of help and giving going on around here, and it really is delightful. There are nonprofit organizations that do provide assistance for people, and that's also helpful as well. One area where I've seen there's not a lot of help, and I keep bringing up this example, is driving. And that's another area where I'm really fascinated. I'm also seeking some funding to do a study on that. A lot of older adults, especially those I think who are fiercely independent, have a terrible time with not being able to drive. And if they had somebody they could ask to drive them there, some people still would not want to do that, but I think a lot of others would come around to doing that if it were available. And I think that in our society, that's an area where we don't do a really nice job. If there's better public transportation, it wouldn't be as big a deal, but the research suggests that especially in rural areas, obviously we're not going to get the public transportation in all the hollers. So I think that's still an issue. So that would be an area for activism, I think, is trying to get some help for people who can't drive. I think I missed the second part of this question. I'm sorry.
Comorbid traumatic events earlier in life. Do you think that would influence your findings in any way?
That's a really good question. I think that could happen because we do know traumatic events and PTSD specifically are very related to suicidal behavior. And often those can be things that happen early in life that are still having an effect late in life. So I wouldn't be surprised by that at all. Great question. And thank you, Dr. Cottrell, for reading these for me. I sure appreciate it.
No worries, no worries. I did want to mention, and others might have other questions, so please do, but there were two things that popped into my mind during your presentation, and that the phrases would be assistive technology and self-advocacy. And in the area of disability, we're constantly striving to provide services and support that lead to self-advocacy. So the question, I think, particularly related to what Elizabeth was asking about whether this is chronic or an acute, the longer they've had the disability, the more time, perhaps, may not always be the case that they're associated that way, but they've heard more and they've developed more skills on self-advocacy, which I don't know how that would be associated with compensatory strategies, if that leads to more independence or if that leads them to develop the skills to ask others to help, honestly, or maybe both. So I thought of that piece. And then the assistive technology, or when they aren't, like you spoke of, when they're not able to complete an activity the way they did prior, that fits in so that they could complete that activity. They just need to go at it a different way using a different tool of some sort or approach. And so I wonder, we have a couple people from that program, and I wonder, are we looking at the profiles of individuals that you're talking to? Are those that use compensatory strategies more likely to approach the assistive technology program, for instance, and seek that change in approach in the first place, and then they work with them from there on to think of it a little differently. So,
Yeah.
yep, I think a couple of areas that we strive, if we're doing it right, could influence your results a little bit. Would be
Really. Oh, so much so, yeah. In fact, I got a chance to meet Dr. Ramana Reddy. I don't know if you're familiar with him over in engineering, and he and his group are doing some really amazing things. And yeah, it does give you hope.
Mm-hmm.
Yeah, I have to find a way to build this into some additional research because, you know, yeah, it's hard to predict. I think people usually assume that older adults are not going to adopt new technology, but if it actually is designed in a way that meets their needs, certainly I think some of them will.
Mm-hmm. So. Well, thank you. Other questions that people might have that aren't in the chat? All right. Well, not hearing anything, I think we're coming to a close. And Dr. Fiske, thank you so much for joining us. It's really interesting to hear your research, and we look forward to, please share future things that you do, because I think it does interact with what we're doing out here. So thank you so much for your time. And thanks to everyone for spending your hour with us as well to hear Dr. Fisk's research. All right, everyone have a nice afternoon. Absolutely, Dr. Fiske. Thank you. We'll have to bring you back again.
Thanks.
Take care.
Bye.